Let us put ourselves in the holy presence of our Lord. Our dearest Heavenly Father, thank you for making all things possible. We are grateful for all the blessings you are pouring upon each one of us, despite the challenges we are all currently facing. Thank you for blessing us today with the wonderful opportunity to meet virtually and learn together in the awesomely exciting webinar. May your blessings of wisdom and guidance be upon us, all through the sharing and impartation of knowledge and skills by our resource speakers, facilitators, and moderators. May all of us learn together, upgrade our competencies, and capacitate us to be the help in the development of our learners' lives and communities in the spirit of your love and generosity. May we now humbly commit every part of this webinar to you as we all bring you the glory, honor, and praises for your kingdom and holy name's sake. All this we pray in the precious name of our Lord and Savior Jesus Christ. Amen.
Through the dreadful darkness, we shall be the light and lead a path to wisdom. Our will to be our light. To those in pain and suffering, we shall hear a call. With arms to care and comfort, compassion above all, to face the brighter future, bound in unity, the Trinity College of this nation, we shall be. Hand in hand, building a stronger nation, this
The Philippine College of Physicians, through the Committee on Media Communication and Health Forum, presents its bi-monthly lay forum to promote the advocacies and mission of the college and its component and affiliate societies. An avenue of accurate and up-to-date conversations with the media and the general public, with timely and diverse topics covering vital public health and medical information, straight from the experts. In a platform that is convenient, accessible, and highly engaging. Welcome to the PCP Health Forum.
Those watching us both from the Zoom platform and Facebook Live. I would like to welcome you to the new fiscal year of our dear PCP. Today, we will be discussing another relevant and timely topic, but before we start with our first health forum for the year entitled Metabolic Associated Fatty Liver Disease, Sounding the Alarm on a Silent Epidemic, let us welcome our President of the PCP, Dr. Ron Jim Solante, for his opening remarks.
Colleagues, media friends, and all our viewers and listeners of this webinar through the PCP Facebook page and through this Zoom platform. A pleasant morning to all. Our topic for today, metabolic associated fatty liver disease, or previously termed non-alcoholic fatty liver disease, is a leading global cause of liver disease and is fast becoming the most common indication for liver transplantation. Over the past 2 decades, MAFLD has become the most common chronic liver disease, and the global prevalence is like 25.24%, with the highest prevalence in the Middle East, followed by South America, Asia, North America, and Europe, whereas this is less common in Africa. In China, the increase in the prevalence of this MAFLD was from 23.8% in 2001 to 32.9% in 2018, and it's continuing to increase along with the increasing prevalence of metabolic syndrome, diabetes, cardiovascular disease, and other chronic metabolic diseases. It is predicted that by 2030, the number of MAFLD cases will be around 314 million, suggesting the tremendous impacts of MAFLD in upcoming decades. MAFLD is likely to become also the leading global indication for liver transplantation within the next decade. This changing epidemiology brings the challenges of managing aging, comorbid patients on the waiting list through the peri-transplant period and the long term. However, post-LT outcomes in MAFLD patients appear similar to non-MAFLD indications, which implies that with good recipient selection, the outlook for MAFLD patients undergoing liver transplantation is optimistic. The rising prevalence of MAFLD has implications for both living and deceased donors' liver, and balancing graft quality with organ demand will be an ongoing issue for transplant programs. As the conceptualization of MAFLD evolves, so will the ability to better predict disease behavior and progression, to tailor treatment, and to observe patterns of outcomes in liver transplantation across the patient's spectrum, and therefore address the multiple challenges posed by this disease. So please stay and do not miss out on this chance to gain valuable insights and have your questions answered by our expert speaker, Dr. Wendell Espinosa, the president of the Hepatology Society of the Philippines, and moderating him is our own immediate past president of the Philippine College of Physicians, also a hepatologist, a globally known GI liver disease specialist, Dr. Diana Payawal. Happy viewing, enjoy watching and listening while you learn.
Thank you, Dr. Solante, for your welcome remarks. Today, indeed, we are very privileged to have experts online to teach us more about this growing silent epidemic. So before we start off with the formal webinar or lecture, I would just like to remind everyone that you could type in your questions in our chat box in the Zoom platform and also in the Facebook Live. Questions, comments, or clarifications are very welcome. We will be having our Q&A after the lecture, so please just prepare your questions. So I will now introduce our speaker and moderator for this webinar series, for this webinar this morning. We are very privileged to have our speaker, Dr. Wendell Z. Espinosa. He is the president of the Hepatology Society of the Philippines, an active staff section of gastroenterology at the Dr. Pablo O. Torre Memorial Hospital in Bacolod City. He's also a faculty of the College of Medicine, University of St. La Salle, Bacolod, a fellow of the Philippine College of Physicians, Philippine Society of Gastroenterology, Philippine Society of Digestive Endoscopy. He took his fellowship in gastroenterology at the University of the Philippines, Philippine General Hospital, a fellowship in therapeutic endoscopy at the Rajaviti Hospital, Thailand, University of Tokyo Hospital in Japan, and fellowship in hepatology at the Chinese University of Hong Kong, China, Kaohsiung Changgung Memorial Hospital in Taiwan. And to moderate his lecture, we have no other than our immediate past president, Dr. Diana Payawal, to moderate his lecture. As well-known, ma'am is the immediate past president of the Philippine College of the Physician. We are very proud of you, ma'am, all your achievements last year. She's also a professor too at the Fatima University Medical Center, a chair of the Department of Internal Medicine at the Fatima University Medical Center in Valenzuela, also a chair of the Hepatology Committee section of Gastroenterology, Cardinal Santos Medical Center. She had her Harvard Medical School Leadership Scholarship Program, Recognition of Excellence Change Management, Harvard Medical School Postgraduate Medical Education, and also because of her passion and advocacy, she is also a past president of the Asian Pacific Study of the Liver, Philippine Society of Gastroenterology, and Hepatology Society of the Philippines. So colleagues, friends, our followers, listeners at the Zoom and Facebook Live, I will now let our speaker and moderator take the floor for further discussion. Thank you.
Good morning. In behalf of the Hepatology Society of the Philippines, I would like to thank the Philippine College of Physicians for giving us this opportunity to deliver this lecture as part of the celebration of the International NASH Day to promote awareness on metabolic-associated fatty liver disease. Metabolic-associated fatty liver disease is becoming the most common cause of chronic liver disease globally. Awareness of MAFLD and liver health is generally low amongst the public and even among healthcare professionals outside of the liver specialists. The majority of people with MAFLD do not have symptoms, leading to the condition being described as silent. Symptoms often only present once the condition is more advanced, when a patient's prognosis is already worse. The lack of symptoms increases the risk that MAFLD will go undetected and therefore untreated. Consequently, unmanaged MAFLD can progress to life-threatening liver complications. A quarter of the world's adult population is estimated to have MAFLD, with Asia Pacific, Latin America, and the Middle East having the highest prevalence. The global burden of MAFLD is predicted to increase by 1 to 6% in these regions by 2030. The disease causes substantial burden of morbidity and mortality and is associated with large healthcare costs and economic losses. There is no national prevalence data available yet for the country, but a study published in 2008 showed that the prevalence of MAFLD in a tertiary public hospital in Manila to be 12.2%. And more recently, in 2020, a study reported that the prevalence of MAFLD in a private hospital was at 38%. Back then, it was still called non-alcoholic fatty liver disease. We surmise that the prevalence of MAFLD in the Philippines will continue to rise. In the Philippines, the prevalence of overweight or obesity among adults showed a gradually increasing trend from 16.6% in 1993 to 31.1% for both 2013 and 2015. Further, the prevalence of diabetes in our country is also increasing. This is a study which predicted the increase of MAFLD by 2030. Say, for example, in China, there were 243 million cases of MAFLD in 2016. It is predicted to rise to 314 million by 2030. Now, how does MAFLD come about? Triglyceride accumulation is the initial step in the development of MAFLD. Storage of triglycerides is not particularly harmful, but other lipids such as diacylglycerol, cholesterol, and saturated fatty acids are particularly toxic. Insulin resistance and inflammation in adipose tissue leads to increased secretion of inflammatory cytokines. This inflammation in the liver is coupled with lipotoxicity, which promotes hepatocyte cell death. Then, the repair mechanism, including fibrosis, is activated. The term MAFLD encompasses all fatty liver disease states, starting with pure steatosis through steatohepatitis, which is the inflammatory state that can lead to advanced fibrosis or cirrhosis. Based on a pooled analysis of patients with NASH, it has been estimated that 37.6% of patients have progressive fibrosis over a span of 5 years. Surprisingly, 39.1% of patients with just steatosis may develop advanced fibrosis, albeit at a slower rate. Predictions suggest that the burden of MAFLD will grow further in the next decades. These epidemiologic trends have made MAFLD-induced cirrhosis a leading cause of liver cancer. The global incidence of liver cancer-related MAFLD is projected to increase from 47% in 2016 to 130% in 2030. Although the development of cirrhosis appears to be a major driver of hepatocarcinogenesis, some evidence indicates that patients with MAFLD may develop HCC at stages earlier than cirrhosis. Moreover, it is predicted that there will be an increase of decompensated cirrhosis, liver cancer, and liver-related deaths by 2030 among patients with MAFLD. This is a study that estimated the economic burden of NASH among European countries in 2018. The proportion of adult NASH patients with a diagnosis ranged from 11.9% to 12.7% across countries, which increased to 38.8% to 39.1% for advanced fibrosis. The total economic costs, which includes health system costs, productivity costs, and other economic costs, ranges from 435 million to 3.6 billion euros for each country. Now, who should we screen? APASL and EASL recommends the use of ultrasound in screening overweight, obese, patients with prediabetes or type 2 diabetes, and those with metabolic syndrome, while the AASLD prefers transient elastography as it can quantify liver fat and fibrosis. The majority of people diagnosed with MAFLD can be managed in the primary care with lifestyle modifications that target diet and physical activity. Individuals with more severe disease benefit from specialist management led by a pathologist or a gastroenterologist. People with MAFLD often have other conditions or comorbidities that require multidisciplinary care, the coordinated management of care across different medical specialties. Therefore, it is important to raise awareness of MAFLD among primary care providers. It is equally important to support the awareness with information and tools to assess the severity of MAFLD and identify those who will benefit from referral to specialist management. In 2020, the Asia-Pacific Association for the Study of the Liver has published the guideline on the management of MAFLD, and we are very proud to claim that the Philippines has been represented in the formulation of this CPG through Professor Diana Payawal and Dr. Ian Kua. Basing on this APASL guideline, a fatty liver among individuals who are overweight or obese or diabetic can be labeled to have MAFLD. Patients who are lean and having a fatty liver can still be labeled as having MAFLD if they have at least 2 metabolic risk factors such as dyslipidemia. Compared to the old criteria in Western countries, the new algorithm is developed from a positive criteria regardless of alcohol consumption or other concomitant liver diseases. A clinical pathway has been published to identify patients at risk of advanced fibrosis using a sequential screening with FIB-4 score and liver stiffness measurement. A detailed lecture on this approach can be seen on the on-demand access in the PCP 53rd Annual Congress. A recent study showed an improvement in liver histology in 58% of those achieving more than 5% weight loss and in 90% of those achieving weight loss of more than 10% respectively. Only the latter demonstrated an improvement in fibrosis stage in 45% of cases. A randomized clinical trial showed that both vigorous and moderate exercise were equally effective in reducing intrahepatic triglycerides, and the effect appeared to be largely mediated by weight loss. For patients with steatohepatitis, a liver biopsy is currently the only reliable means to diagnose steatohepatitis. Alternatively, a FAST score using LSM, CAP, and AST can be used. Patients with steatohepatitis with advanced fibrosis or cirrhosis, with or without type 2 diabetes, showed improved transplant-free survival and lower rates of hepatic decompensation among vitamin E users. Liraglutide improves steatosis proportional to the magnitude of weight loss, and more recently, semaglutide improved liver histology in 59% of patients with biopsy-proven NASH, with or without type 2 diabetes. And lastly, pioglitazone improves steatohepatitis in patients with biopsy-proven NASH, with or without type 2 diabetes, although there are some issues with the use of vitamin E and pioglitazone. Moreover, different associated diseases are found among patients with MAFLD. 51% of MAFLD patients are obese. Moreover, 69% have dyslipidemia. Further, 39% have hypertension and 23% are diabetic. In managing these cases, if we are not hitting our targets, we should refer these patients to diabetes clinic, weight loss program, and cardiology specialists for optimal management. We have highlighted that MAFLD is a public health issue because of its rising prevalence and because of its clinical and economic consequences. So, who needs to be in the know? We must educate the public through online health information such as the PCP Health Forum, advocacy champions, and engage in existing civil society groups such as the Yellow Warrior Society of the Philippines. Also, the primary care practitioners. They are often the first medical professionals to see patients with MAFLD, making raising awareness within this group as a strategic priority. Moreover, given the strong links between MAFLD and other non-communicable diseases, particularly cardiovascular disease and diabetes, non-liver health specialists are also critical stakeholders to engage. And lastly, there is a little awareness of the disease among national decision makers. The high prevalence rate, current lack of clear policies or strategies, and the health and economic impact of MAFLD should be emphasized to this group to make a case for investment. This is a study from Latin America which identified the challenges to address this public health issue. Despite a growing global health problem, MAFLD is mostly underappreciated. Proper recognition and assessment of MAFLD in the clinic is key to deal with the growing number of patients with the disease. Thus, continuous education on topics such as case finding, risk stratification, and referral pathways should be promoted for all healthcare professionals involved in the management of patients with MAFLD-associated conditions. The management of this disease requires a multidisciplinary panel of caregivers, including primary care practitioners, endocrinologists, and hepatologists, among others. Unfortunately, the fragmented healthcare system that exists in the region with poor communication between specialists and between different levels of care do not lend themselves to the creation of a multidisciplinary teams of medical and allied health care professionals to tackle the multiple MAFLD-associated comorbidities. Further, the reason for low research output is likely related to factors such as insufficient availability of funds, among others. And lastly, it is essential to have a public policy to reduce and manage the burden of MAFLD and its health consequences. Tackling the public health challenge of MAFLD will require a strong political commitment and multi-sectoral collaboration. Reversing the trend of growing MAFLD prevalence requires a comprehensive approach that includes public health response, addressing the underlying causes and its links with other non-communicable diseases, a clinical response that improves diagnosis, treatment, and multidisciplinary coordination of care, bridging clinical community, care providers, and public health authorities. In summary, the increasing prevalence of MAFLD makes it a public health concern. It is a rising cause of cirrhosis and liver cancer with grave clinical and economic consequences. This disease is not a concern of gastroenterologists or hepatologists alone. A multidisciplinary approach is warranted in the management of MAFLD patients to optimize outcomes. And lastly, MAFLD is not only the problem of physicians, but a concern which includes the community and our government.
Thank you, Dr. Wendell, for that lecture for us to understand more about the burden and the emerging problems of metabolic associated fatty liver disease and its impact to the community. So may I call on our dear Dr. Payawal, ma'am, to moderate po the discussion and the question and answer for this lecture.
Thank you
Morning po.
so much, Ginger, and thank you very much, Wendell, for that very elaborate discussion. I'd like, of course, to thank Ginger for being equally active last year and until now, so thank you. Okay, there are some questions in the chat box before I actually give my own questions, so maybe you can give some thoughts on this. How long can Silimarin be given? This is the first question from an anonymous attendee.
Hi, good morning. Again, we'd like to thank the Philippine College of Physicians for giving us this opportunity to raise awareness on metabolic-associated fatty liver disease. Thank you po, ma'am, and thank you, PCP. Anyway, with regards to the question, 60 to 70% of patients with MAFLD usually falls on the low risk. The other 30 to 40% will fall under moderate to high risk for fibrosis. Most of the time, the cornerstone of management would be a lifestyle modification, which is weight loss, at least 3 to 5%, which can be achieved through hypocaloric diet and also through physical activity. No? With regards to pharmacotherapy, going back to the questions, most of the studies with Silimarin or other health supplements usually would tend to lower down the liver enzymes such as ALT and AST. But it is not addressing the problem, such as decreasing the fats in the liver, decreasing fibrosis. So maybe it is safe to assume at this point that the evidence as of this time is not that robust yet in order for us to put it in our prescription as a mainstream drug therapy.
Okay.
Maybe you can add to that, ma'am.
Yes, thank you, Wendell. Okay, for us too, since I'm looking at the audience, and there are a lot of probably lay or internists or general practitioners who are actually listening. So siguro muna tingnan natin, what is the risk of having fat in the liver? So I think, is there a risk? Do you develop liver cancer? Do you develop cirrhosis? Siguro yun, dun muna tayo. And then we'll go to treatment. Because if you understand the pathophysiology of a cause of a disease, then treatment will be very easy for us to handle. So siguro, Wendell, ano ba ang masama kung mataba ang ating atay?
Thank you, ma'am, for that question. Anyway, so the spectrum of metabolic-associated fatty liver disease goes from steatosis, just a simple fatty liver, 20 to 30% of these patients will go to a more severe form, which is the non-alcoholic steatohepatitis, meaning there is already inflammation and cell damage. More than 30% of these patients with NASH is going to have an advanced fibrosis. Ito na po yung nagkaka-cirrhosis na yung patient. So we think it's cute to have a fatty liver. No, hindi. It has grave consequences. No, up to 30% of these patients may develop cirrhosis. No, and later studies have shown that patients, even with just steatosis, can jump to advanced fibrosis. No, although at a lower rate compared to those patients with NASH. So the risk of having cirrhosis and eventually liver cancer is very real. No, in fact, it is predicted that worldwide, maybe it will be the most common cause of HCC in the future.
Okay,
Thank you, ma'am.
so ganito na lang. Well, what Wendell was trying to say was that fat is like a stimulus, no? Para siyang, it creates a wound in the liver. So pagka may sugat ang atay, just like any wound, it produces a wound healing strategy. And this is where now you develop inflammation kasi you are reacting to a wound, to a stimulus. And this inflammatory process in the liver now produces now fibrosis, cirrhosis in the future. Pero I think what is evident here is that Wendell was able to show that with fat in the liver, you do not necessarily develop cirrhosis. You can develop already liver cancer without passing through the chronology, di ba? Liver inflammation, hepatitis, cirrhosis, cancer. Ganun po talaga eh. Kahit sa hepatitis B, ganun. Sa Hep C, ganun din. Ano? Pero ang Hep B at fatty liver, minsan lumalaktaw. Minsan wala na yung cirrhosis, lumalaktaw na sa liver cancer. And I think Dr. Wendell, who is the president of the Pathology Society of the Philippines, was able to elaborate on that. Okay, so having said that, now we have shown the link, no? How do you now determine it in your practice? Paano mo malalaman na ang pasyente may fatty liver disease? So siguro like with primary care physicians, do you need biopsies? Do you need high-end tests? How do you assess this in practice, Wendell?
Thank you po, ma'am, for that question. No? Okay, with regards to screening, no, according to the liver societies, hindi po dapat lahat ang isa-screen natin. Maybe to make it more cost-effective, we will target those people who are high risk. These are patients who are diabetic, patients who have metabolic syndrome. Metabolic syndrome, ibig po sabihin, may mataas na cholesterol, high blood pressure, mataas yung sugar, at yung mga pasyente na overweight. Ang definition po ng overweight sa Filipinos or Asians is a little bit stricter compared to the West, no? Overweight, the definition of overweight is more than 23 na BMI compared po sa West na 25. So yun po, ito po ang dapat ita-target natin. So how about the tools, no? How do we screen these patients, no? The Asia Pacific Association for the Study of the Liver, where we belong, and the European Association for the Study of the Liver recommends the use of an ultrasound. Yes, it is not that sensitive compared to the FibroScan, no? Or the liver elastography, which our American counterparts recommends. Ito naman po yung recommendation sa Amerika, transient elastography, because it can quantify fat and fibrosis all at the same time. But anyway, going back to our scenario, ultrasound is ubiquitous, much cheaper, and we can use that tool, no? For example, if we don't have ultrasound in our locality or malayo tayo sa ultrasound center, meron naman pong liver tests. For example, the fatty liver index, no? Kailangan lang po ng BMI, waist circumference, GGT at saka triglycerides. You can calculate the fatty liver index na po, no? But mainly it's ultrasound. identifying high-risk patients.
Okay, so I think Wendell was able to elaborate that the first test you do probably will be an ultrasound, no? So dati kasi pag may fatty liver sa ultrasound, binabaliwala natin. But that was actually during the time where I was a fellow, but these patients now became problematic through time, no? Let us go back to some of the questions now that we understand how to monitor them and see them. Okay, this is from Lavinia Laika Lopez. Thank you for listening. How long can Silimarin be given with fatty liver? A patient with long history of increased AST and ALT took it and liver enzymes improved. But should liver Silimarin be continued for several months given that the enzymes are normal? Or should we stop it when there is already, even if there is still fatty liver in the ultrasound? So, Wendell.
Thank you for that question po. Anyway, so with regards to Silimarin or other food supplements, no, yes, it can lower down liver enzymes, sure. But the problem with this is, the question would be, is it effective in addressing the root cause of the problem? Doon po nagkakatalo yung ano doon po yun po yung importante. Yun nga, studies have shown that it's not effective in reversing fibrosis, no? So ito po kasi, why am I always thinking about fibrosis? Ito po kasi yung determinant for liver-related and non-liver-related complications, no? So I guess yung quick answer doon is you address the problem, no? So weight reduction through hypocaloric diet and physical activity, yun po. Then maybe you can stop it kung bumaba na po yung weight, at least po 5% ng weight loss. Thank
Okay,
you po,
so
ma'am.
siguro ganito. There are 4 etiologies of fatty liver based on metabolic associated fatty liver disease. 10% over excess body weight, di ba yan yung obesity? Yung sinasabi po natin na diabetes, that is diabetes both insulin requiring and non-insulin requiring. And of course, the third is actually those patients who are lean, so normal yung weight pero may metabolic problems. And these are patients with the metabolic syndrome, those patients who have high HOMA score, serum insulin assay. So medyo elaborate na to kasi minsan nakakita tayo ng normal weight na pasyente and yet by ultrasound they are actually fatty, no? So this for me is quite problematic kasi unlike diabetes or obesity, pag nakita mo, sir, magpapayat tayo, pero yung sa and you can reverse because 10% of reversibility of weight can actually reverse even fibrosis. Pero itong mga normal weight pero may metabolic syndrome, these are the ones you really have to find in your clinic. Hypertension, alam niyo naman yun, ano? Hypertension, HOMA score, trigly, those were all mentioned by Dr. Espinosa. So, siguro ang key dito, if you find the cause, then you reverse it. So, obesity, sinasabi ni Wendell, ibaba yung weight. For diabetes, do you think a control of diabetes will actually reverse or decrease your chances to develop fatty liver disease adverse effect, Wendell?
Yeah, certainly po, ma'am, no? Control, ito pong mga comorbidities na sinasabi po natin, ano? Ito po yung nag-hasten ng mechanism for fibrosis, no, and adverse outcome ng metabolic associated fatty liver disease. So certainly if we control them, it can spell out a better outcome po, ano? Masegue lang, no? For patients with for example diabetes, no, who have metabolic associated fatty liver disease, no, maybe we can use those drugs or pharmacotherapy that has how can you call it, benefit po sa liver, no? For example,
collateral damage, the collateral effect that produces
Yes, yes.
so
For
if
example, yung
say both from the Philippine College of Physicians and the Pathology Society of the Philippines, that if you actually monitor your metabolic parameters, be it cholesterol or triglycerides or diabetes or sugar, then you actually will see an improvement in your fatty liver. Okay. So what can you advise patients regarding reversibility of steatosis in ultrasound? So ganito natin tingnan, no? Our key for a patient to be brought in our attention is an imaging test of fatty liver on ultrasound. Therefore, for us to show that this patient is improving is you don't see fatty liver on ultrasound. So how do you now advise? This is a question from Odessa Ramos. Your first name is interesting, huh? Critch. Critch. Critch has a question and wants to know, siguro meron siyang pasyenteng may fatty liver, worry siya na tuwing ultrasound siya, may fatty liver yung pasyente niya or siya. Is this now, how do you reverse this fatty liver and ultrasound? And is it really logical for you to use ultrasound as reversibility or non-fatty liver disease and ultrasound as a parameter to say that your fatty liver is improving?
Thank you very much for that very relevant question. No, actually, we're referring maybe to the clinical pathway on managing patients with MAFLD. No, so magbabacktrack lang ko ng konti. Okay, so among patients with MAFLD, sino po ba yung kailangan i-prioritize natin? No, meron pong na-publish na clinical pathway with the American Gastroenterological Association, also with the AASLD just recently, and the ESL few years ago. Maybe we should screen these patients, no, with advanced fibrosis. Ito po kasi yung sinasabi natin na determinant ng mortality and morbidity yung liver fibrosis. So very simple lang po yung kailangan natin. So kung may ultrasound po tayo na fatty liver, get a FIB-4 score. Yung FIB-4 score po, ano lang po yan, ALT, AST, and age platelet count. So meron po tayong we can HSP has developed an application or parang MedCalc local version. We call it PH liver tool. So meron po dyan FIB-4. You can just type in all those information, platelet count, AST, ALT, and age. Then they will give you a FIB-4 score. Yung FIB-4 score na ito, pag mababa, meaning less than 1.3, it has a negative predictive value of more than 90%. Ibig po sabihin, wala po siyang significant fibrosis. And we can follow this patient every 2 to 3 years, as long as yung associated metabolic conditions po nito are controlled. For patients naman po na more than 1.3 or ibig sabihin mataas yung probability of having a advanced fibrosis, ito po yung mga pasyente na kailangan natin pong i-subject sa liver stiffness measurement. So ito po yung second na screening, yung liver stiffness measurement. Pag less than 8 po kilopascals, so again, this is a low-risk patient. So monitor these patients every 2 to 3 years. Probably the non-invasive tests. When I say non-invasive tests, ito po yung ultrasound, FIB-4 score. But if the LSM or ibig sabihin yung tigas or stiffness ng liver is more than 12, very high risk po ito for clinically significant liver fibrosis, no? For patients with fibrosis already or mataas yung FIB-4, mataas yung liver stiffness measurement more than 12, ito pong we have to follow every year. Lalo-lalo na po if the patient has already cirrhosis, no? So masyadong mataas na po yung LSM score niya, more than 15 or perhaps 20 kilopascals na po. Masyado na po matigas yung liver. This one po, you need to follow up every 6 months. No, going back to your question, So what do we use, no? Ultrasound, simple fibrosis scoring, no? If available po sa locality natin, then imaging such as the transient elastography.
Okay, so I think what Wendell is trying to say is when you develop fat in your liver by ultrasound, you go one more step in finding two risks. No? One is, of course, finding fibrosis. Importante po yun, yung tigas ng atay. Eh baka fatty liver ka ng fatty liver, yun pala, matigas na yung atay mo. So, because when you have fibrosis, cirrhosis, or yung tigas ng atay, that means your liver now has a risk to develop more cancer because that is cirrhosis is of course a fertile ground for liver cancer to come. So importante po malaman natin na kung ang pasyente natin po ay may tigas ng atay, then you have to follow up your patients closely and probably work with your gastroenterologist or hepatologist. Okay, number 2, doon naman kunyari nakita mo wala naman tigas, taba naman ng atay pero severe, no? Nandun sa well, I do measure my controlled attenuated parameters. So kasi para sa akin it gives you a number, no? So and that number when you see it to be decreasing, kunyari 300 naging 250, ay sir, tama yung ginagawa. This is very important because in clinical practice you have to have a parameter to assess outcome. Kung gagamitin mo yung ultrasound, minsan, laging sasabihin lang ng ultrasound, taba ng atay. But you don't know, yung taba na pala yun, less na, more na. And you know, this is very subjective to the ultrasonographer. So kung yung mata niya sanay na bumabasa ng mga mild, sasabihin niya medyo mild. But you know, with some parameters that will tell you exactly the number, parang sa cholesterol, di ba? May 250, naging 200 next month. So, oh, sir, pwede na natin bawasan yung gamot mo kasi bumaba na yung cholesterol mo, no? So, these are things you have to follow up, no? So, unlike before, we don't have these parameters. Ngayon, what Wendell is trying to say is we have parameters to assess whether our fat in the liver is actually decreasing. I use it actually as a way to encourage our patients to treat, no? Kunyari, bumaba yung kanyang weight. Doktora, kasi sabi mo, pagka yung fatty liver ko, pag nag-weight loss, kaya hindi ako mag-weight loss, you know, weight loss is really difficult. There are times that you plateau. Nagpa-plateau ka. Pero pag tingin mo sa elastography mo, minsan gumaganda naman yung fat. Oh, sir, tama yung ginagawa mo. So these are encouraging the real world scenario when you deal with patients for a long time, when you want reversibility. So to answer your question, Dr. Ramos or Odessa, the best way to advise reversibility is actually to see first the whole picture of your patient. Talaga bang mataba ba talaga yung atay nito? Gaano kataba? And then you tell your patients, oh, ito po sir, pag nakita ho natin bumababa, that's a sign of reversibility. When you talk of reversibility, baka akala mo yung fatty ngayon, tapos bukas wala na. Doesn't happen. So you need, it's a process. So it's a long process and that's what Wendell is trying to say. Okay, going to statins. This is a more common, lagi na lang to tinatanong maski saan. So this is from Kevin Fulio. So, sir, thank you for informative talk. May I ask, is it more effective to reverse steatosis? Kasi nga naman, fat. So, ang fat natin is synonymous to cholesterol. Is it high-dose statins and ezetimibe? Or this is ezetrol, no? So, in our patients with steatosis, okay, siguro ang unang, kunyari mataas yung SGPT. Pwede ba tayo magbigay ng statins, Wendell? What do you think?
Maybe I will take it as kung mababa naman, less than 3 times the upper normal limit, maybe sure. I will give it kasi yun nga, sir, no? Importante kasi sa management yung, ng MAFLD, yung controlling the comorbids of these patients. So is either you use ezetimibe or statins, high-dose statins as long as you're hitting your target. Bumababa yung cholesterol ng patient, that would be very beneficial, no? Maybe for medyo mataas talaga yung SGPT, tapos iba naman yung cause, maybe I would start, for example, may Hep B yung patient, mataas yung SGPT, tapos mataas yung cholesterol ng patient. Kahit more than 3 times the upper normal limit, maybe I will start the patient on a statin, because statin is very beneficial among patients with MAFLD. Then maybe slowly titrate po until I hit the target, no? Then monitoring also the liver enzymes as well. Maybe you can add to that, ma'am.
Okay, I think this you have explained it quite well. For patients who's ito po, no, pag may fat in your liver, you have to find the metabolic causes. So, kunyari, payat. Ay, payat naman to, bakit mataas ang ano? So, kunin mo lahat, ha? You have to also take note that you need to screen for hepatitis B, hepatitis C, especially the genotype of hepatitis C. There are certain genotypes that are actually linked to hepatic steatosis. So, Hep C should be screened, Hep B should be screened. I even go one more step in determining ANA and AMA. Now, if you find out everything is normal and you still have severe fatty liver disease and you find out it is cholesterol, then you can actually monitor the patient. I think the caveat here is you need to continue to follow up. So, kung mukha sinabi ni Wendell, kung magbibigay ka ng statins, o basta after 3 months, sir, babalik kayo, or 1 month, babalik kayo, tingnan nyo kung yung SGPT bumababa. These are things that you need to explain well because it is a double-edged sword. Sometimes, you know, it can have an idiosyncratic effect, and sometimes it can have no effect at all, no? So I think the key here is if you are going to put a new drug in a patient who is deemed to have a liver disease, then you have to monitor whether it is any herbal medication. Ako, number 1, di ba, sinabi natin, number 1 cause of drug-induced liver failure ngayon is herbal medication. In fact, vitamin A, which is supposed to be good, no, is linked to also drug-induced liver injury. So I think we have exhausted all aspects, talked about the etiology, the diagnosis, and the treatment. I think Wendell has been very elaborate and very nice enough to answer all the key questions that were raised in the panel discussion. So I'd like to thank Wendell Espinosa, Dr. Wendell Espinosa, our president of the Hepatology Society of the Philippines, for answering all the questions and giving a very good discussion of the case. And on behalf of the Philippine College of Physicians, we'd like to thank Hepatology Society of the Philippines for coming up with such elaborate discussion on MAFLD. I think this is the new epidemic, a silent epidemic, because just like any liver disease does not have symptoms. You develop symptoms if you are in the end stage of liver disease, and that's not what we wanted. That is why we come up with webinars, so you will be able to understand its scenario early on. Having said that, I thank, of course, Dr. Ginger Samonte for giving us this forum, because I think our advocacy has always been to screen patients early on who may have a risk to develop liver disease. Having said that, thank you, and I give it back to Ginger. Thank you, Ginger.
Thank
you
you,
very much,
ma'am.
ma'am.
Thank you, Dr. Wendell, for your informative, practical approach to this growing problem. Medyo tahimik no? Kasi tama, agree ako kay ma'am. Kasi nung araw, di ba, pag fatty liver, ay huwag pansinin niya, wala lang yan. Ganyan sabihin, diet ka lang or observe lang. Pero it turns out na dumadami ngayon ang problem sa liver, cancer, and cirrhosis because of this problem. Ay, sir, may pahabol lang, Dr. Payawal, if I may, and Dr. Wendell. Is it the same answer for the Essentiale Forte tablets daw? Is it recommended to give at this point? And if warranted, is it possible daw?
Siguro I will take that, Wendell. Is that okay?
Yeah, sure po, ma'am. Sure po.
Please let us not use trade names, no? I think trade names are not there. Phosphatidylcholine is a is a mechanism or is the component of essential forte. So I think what is evident here is you have to find the cause. So address the cause, and there is no drug for all seasons. In other words, you have a disease and you give all of these antioxidants. Find the cause, see if it affects your mitochondria. Phosphatidylcholine is actually on the membrane of the hepatocyte. And having said that, the membrane of the hepatocyte is not where fatty liver disease, metabolic associated fatty liver disease acts on. It acts on the mitochondria. So you have to give drugs that are linked in the mitochondria of the hepatocyte.
Okay, thank you, ma'am, for that straight answer. Very clear.
Thank you po, ma'am.
So, thank you, Dr. Wendell. Thank you, Dr. Payawal, for your passion and strong advocacy in promoting good liver health in the country. So, before I formally close this media forum and health forum, may I call on the Vice President of the Hepatology Society of the Philippines, Dr. Losada, to give his closing remarks.
Thank you, Dr. Samonte. So on behalf of the Hepatology Society of the Philippines, we would like to extend our appreciation to the Philippine College of Physicians for the invitation to this excellent forum. The awareness of liver disease, especially fatty liver and NASH, is one of the advocacies of the HSP. And the prevalence of this illness is truly a silent epidemic that affects a majority of our population, which has been emphasized and explained extensively by our president, HSP, Dr. Espinosa, as well as Dr. Payawal, our immediate past president of the PCP. So the pandemic has actually brought about good things, and one of them are these webinars that reaches to doctors across the Philippines, wherever you may be. So this forum is timely as we celebrate International NASH Day on June 8th, which is just 2 days ago, 2 days away. So again, congratulations to the PCP and thank you.
Thank you, Dr. Losada, for your closing remarks. So, before we close the media forum and the lay forum, and we'd like to make some announcement from the PCP. So now, to our dear PCP members, you can avail or you could now have on-demand access of our convention held last May. So for those who attended the convention face-to-face, you are already registered for this on-demand access. However, for those who were not able to go on to that at the PICC, you have to register to avail of this on-demand access. So this on-demand access will be available on a limited period only, June 10 to July 10. So please take this opportunity to have the on-demand access for our annual convention kasi ang daming magagandang lectures for us. So only 1 month po after 1 month, hindi nyo na po to ma-access. And we would like to invite you on Saturday, our PCP sa Radio Veritas, I Am Informed, we have another practical and interesting topic on organ donation, the greatest gift of all, with our guest, Dr. Benita Espadilla, an advocate on organ donation. We have our anchors, Father Joel Saballa and Dr. Agnes Cruz. So at 9 a.m. to 10 a.m. at Radio Veritas, and also this is available na mapapanood through our Facebook Live. So take this opportunity again to learn about organ donation. With that, maraming salamat at alam ko na nagsisimula na naman tayo ng another year for PCP for more information, more learning, and more camaraderie among our members. So till next open forum, maraming salamat and thank you to our dear speakers, our Board of Regents for their support in this endeavor of the PCP and to the PCP staff. Maraming salamat until the next health forum.
Thank you. Thank you.
Health Forum wishes to thank its media partners, social media followers, and participants. See you again next time here on the PCP Health Forum.